explain the different biochemical abnormalities in carbohydrate metabolism and diabetes mellitus. Number 4, metabolism of insulin. Explain the metabolism of insulin hormone as to its biosynthesis, functions, relationship with other hormones such as epinephrine, glycogen, growth hormones. Number 5, the TECs such as the Polyphagia, Polyuria, and Polydipsia. Number 6, explain the molecular basis of clinical manifestation of diabetes mellitus. Objective 7 is the diagnosis. Discuss the different procedures for diagnosis of diabetes mellitus. And number 8, prevention and treatment for the diabetes mellitus.
Okay po. So, before we define what diabetes mellitus is, here are some facts po muna. So according to the Philippine Statistics Authority, deaths due to diabetes mellitus ranked fourth in 2020 at 37,265 after heart diseases, cancer, and cerebrovascular diseases. And 4 million adults in the Philippines are diagnosed with common comorbidities and complications associated with type 2 diabetes, including heart diseases. And according to Dr. Michael Villa, president of the Philippine Society of Endocrinology, Diabetes, and Metabolism, of patients with diabetes, 85% of them have type 2 diabetes. So more than 32% of those with type 2 DM have cardiovascular complications, while more than 87% are either overweight or obese. And lastly, diabetes went by 7.8% for the past 3 years following ischemic heart disease, cancer, and pneumonia, listed as the top 3 causes of death in Filipinos. According naman sa WHO, in 2019, diabetes was the 9th leading cause of death with an estimated 1.5 million deaths directly caused by diabetes. Okay, so what is diabetes mellitus? So it is defined as a chronic disease that occurs either when the pancreas does not produce enough insulin or when the body cannot effectively use the insulin it produces. It is defined naman by the Department of Health as a serious chronic metabolic disease characterized by an increase in blood sugar levels associated with long-term damage and failure of organ functions, especially the eyes, the kidneys, nerves, heart, and blood vessels. So here are the risk factors for diabetes mellitus. So included dyan yung obesity, which is number 1, hypertension, hyperlipidemia, sedentarism, family history, and of course, sa type 2 diabetes, which will be discussed later, related din, risk factor din yung age, which is accounts for 3.9%. Okay, as for the differentiation of the 2 types of diabetes mellitus. So the main difference between the 2 types of diabetes is that type 1 diabetes is a genetic disorder that often shows up in early life, while type 2 diabetes mellitus is largely diet-related and develops over time. So what happens in type 1 diabetes is that the beta cells of the pancreas cannot secrete insulin, so the glucose cannot enter cell, resulting now in hyperglycemia. And it is more prone to ketoacidosis. While in type 2 naman, insulin receptors are defective due to a signaling defect in GLUT4, which is a type of glucose transporter. So kapag defective yung yung GLUT4 natin, glucose cannot enter cell and magkakaroon tayo ng insulin resistance. Okay, so here's a table showing the differences of the 2. So in type 1 diabetes mellitus, it occurs usually sa patients less than 20 years old. That's why it is also called juvenile onset diabetes. While in type 2 naman, usually yung patients natin 30 years old and above. And it is also called as adult diabetes mellitus. So for the body mass, usually patients with type 1 are thin or normal. And in type 2 naman, often obese sila. Plasma insulin in type 1 diabetes is absent or low, while in type 2, it is usually normal or usually high. And sa autoantibodies naman natin, usually present siya sa type 1 diabetes. For insulin sensitivity, normal yung sa type 1 and then reduce yung sa type 2. That's why nagkakaroon tayo ng insulin resistance. For plasma glucagon, both sila na high. However, sa type 2 DM naman, resistant to suppression yung plasma glucagon levels. So plasma glucose, both din na high. Syempre, diabetes siya. And then sa type 1 naman, it is more ketosis prone. As for the therapy and treatment, sa type 1 natin, usually ang recommended is insulin drug administration. While in type 2, since adult onset siya, usually lifestyle changes such as exercise and weight loss.
So I'm going to be explaining the biochemical abnormalities in carbohydrate metabolism in diabetes mellitus. Okay, so these next few slides, I'm going to be talking about the general overview of the metabolic effects for insulin deficient individuals. So this is just an overview, and I'll go into more detail. So for carbohydrates, we have an increased blood glucose concentration, an increased glycogen breakdown, and a decrease of peripheral glucose use. And then for proteins, we have an increased protein breakdown, an increased catabolism of amino acids, an increase in gluconeogenesis, and an increase in neurogenesis, and a decrease in protein synthesis. And lastly, for fats, you have an increase in triglyceride breakdown, an increased level of circulating free fatty acids, an increased ketosis resulting in ketoacidosis, decreased fatty acid synthesis, and decreased triglyceride synthesis. Okay, so what is the reason behind the increased blood glucose levels? And so for this would be due to, what was mentioned before, GLUT4 transporters. So an absence of GLUT4 transporters. So GLUT4 transporters are stored in vesicles in the target cells, especially in muscles and in fats. And this is a major pathway for how glucose can get into cells, is through this GLUT4 transporters. And insulin is known to induce the GLUT4 expression on cell surfaces, facilitating the intake of glucose. And so something important to note here is that if there's insulin exposure, there will be GLUT4 on the surface, and vice versa. If there is no insulin exposure, then there will not be GLUT4 on the surface. Right, next slide. And so this leads into all the metabolic pathways. So here's just an overview of several metabolic processes that feed into the major glycolysis and gluconeogenesis in the middle. And so the question is, if a cell cannot get glucose into itself, where can it get its energy from? And so from the different sources, I'm going to be discussing how we can get that energy from stored glycogen stores, from proteins, and from fats. All right, next slide. Okay, so over here is just a picture showing the different hormones. If I'm going to draw your attention to the top, so glucagon, epinephrine, and insulin. So insulin is when you have elevated blood sugar states, it signals glycogen synthase to produce glycogen. So this makes sense. If you have an excess of glucose, you're taking in glucose in, you want to store that glucose for further use. Now, glucagon and epinephrine are elevated in times of fasting or fight or flight. And so they promote more glycogen breakdown to glucose. And so the way this mechanism works actually is that if you follow the arrows, both glucagon and epinephrine, they both end up phosphorylating glycogen phosphorylase and glycogen synthase through the two enzymes glycogen phosphorylase kinase and protein kinase A. And these have opposite effects for the different enzymes. So for glycogen phosphorylase, when it gets phosphorylated, it is actually activated to break down glycogen. And if you phosphorylate glycogen synthase, you actually turn off glycogen synthase, therefore preventing glucose from being turned into glycogen. And so this is important because it's really good to have glucose stored, especially if you're in a fight or flight response. It's good to have energy stores for immediate utilization. And as well as in diabetes mellitus, if you're not producing insulin or enough insulin, that ratio between glucagon and insulin becomes more heavily favored towards glucagon. So more of the pathway of, in this picture, the pathway of the glucagon would be more favored. And so therefore glycogen breakdown will be more favored in diabetes mellitus patients. Okay, next. Okay, so I'm going to be talking about amino acids. So just to remind everyone, there are two types of classifications for amino acids in regards to these pathways here. So we have ketogenic and glycogenic amino acids. And so ketogenic amino acids, these are basically converted to ketone bodies or acetyl-CoA. So based on the picture here, these ketone bodies would be in the form of acetyl-CoA and acetyl-CoA. And this just means that if you're ketogenic, they cannot become glucose via gluconeogenesis. All right, next slide, please. And then we have glucogenic amino acids, and these can be converted to pyruvates or TCA cycle derivatives. Just drawing your attention to the picture again, if you see pyruvate, you could see amino acids can be converted to pyruvate, as well as different other glucogenic amino acids can also turn into the different substrates of TCA cycle. Right, next slide, please. Okay, so how does this all fit into the big group picture? So the goal is to make oxaloacetate or pyruvate in order to create glucose through the process of gluconeogenesis. And so as I mentioned before, there are ketogenic and glucogenic amino acids. So just a note for that is that ketogenic, the reason they don't make or they don't participate in the making of eventual glucose through gluconeogenesis is because those carbons are lost in the TCA cycle due to carbon dioxide. So, so the goal again is to create glucose, is to create that energy source for our body. As well as you can see too, is that amino acids can be directly fed into the TCA cycle, further going down the cycle to processes such as the electron transport chain, creating more energy. So this is also serves as an energy source for us as well, in the absence of glucose. Right. All right, so next talking about how fatty acids are broken down. So it's facilitated through hormone-sensitive lipase. So this is an enzyme that removes fatty acids from triglycerides, as you could see in the picture there. And so glycerol serves as a energy source, which could enter glycolysis, and it could also enter gluconeogenesis, further expanding the options for energy sources for our cells. In addition, free fatty acids are released, and these could also undergo beta oxidation, and they could in turn produce energy for our cells as well. And so this is inhibited by insulin, and this is activated by glucagon and epinephrine. Right, next slide, please. Okay, next, another important enzyme to take note is lipoprotein lipase. So this is released and associates with the capillary endothelial cells, and it allows it to act on VLDL particles floating in the blood. And so basically what it's trying to do is it's trying to bring in more triglyceride molecules so that it could break it down. So this is important in the steps of utilizing other energy sources besides glucose. Next. And as I mentioned before, fatty acid breakdown can be a source of energy, and this is done through the process of beta oxidation. And so this is through the removal of 2 carbon units, just to remind us of just a brief overview of fatty acid breakdown. And The ultimate goal is to produce acetyl-CoA, which could in turn go into the TCA cycle, producing NADH, FADH2, which we know can be eventually converted into ATP through the electron transport chain. Next slide, please. So how does this all tie in? And so a good tie-in to where all of these sort of come together is through diabetic ketoacidosis. And so diabetic ketoacidosis, this is a life-threatening complication of diabetes. It is more common in type 1, as was mentioned before, and it is often precipitated by infection or trauma. So a note on that point is that's due to hormones, right? So as I mentioned before, I mentioned epinephrine. So hormones like these could exacerbate these effects. And so, and an important note to this is it could occur in type 1 diabetic if they happen to skip their insulin therapy. They could develop complications of DKA, which is a disease this is also known for. Next slide, please. Okay, so if we take our patients with diabetes mellitus, they have low insulin. And so paired with maybe a situation where they have high epinephrine, they're going to be using a lot of fatty acids. And so in the picture there, you could see how the fatty acids fit into the picture here. So the fatty acids can be converted into acetyl-CoA in the middle of that picture, and they could combine eventually with oxaloacetate to form citrate, and they can go through the TCA cycle. So that's how normally fatty acids go through the cycle. However, if you have low insulin, you could think about it this way. There is not that much oxaloacetate because the cycle is not going through that much. And so what might happen is you have you could think of it as you have a backflow of a bunch of acetyl-CoA hanging around, which results in an abundance of acetyl-CoA in cells. And so acetyl-CoA doesn't just hang around. They can be converted into other ketone bodies, resulting in ketone production. As you can see on the right side of the picture, two acetyl-CoAs can be turned into acetyl-CoA, eventually turning into acetoacetate, turning into acetone. All right, next slide, please. Okay, so here's just an overview of diabetic ketoacidosis. So I included two pictures here just to remind you of what's going on. And so as I mentioned before, it happens in the situation of low insulin, as you can see on the top of the picture. And this could be exacerbated by high levels of, or with stress or trauma. So what happens is that in DKA, you're going to have high levels of glucose. So low levels, and that means low levels of glucose utilization. And so eventually this leads to more of a breakdown of fatty acids via lipolysis. So you'll have an increase of lipolysis, and eventually this will lead to the development of ketone bodies, as I mentioned. And some of these ketone bodies are acidic, and so that's what it gets its characteristic name of ketoacidosis. And it's noted too that some of these patients have a distinct smell in their breath, and that's due to the aroma of acetone, or from what I read, that's because of that. So you might smell it on the breath of these patients as well. And so you might detect ketones in the urine as well. But those are just important things to note about. So how this all plays in is through this disease called diabetic ketoacidosis. Right, next slide, please. So I'm going to talk about insulin hormone. By this function in relationship with other hormones such as epinephrine, glycogen, and growth hormone. Okay, next slide, please. All right, so insulin is so an overview of insulin, it's a protein hormone. So as we know about protein hormones, they cannot cross the cell membrane. They have to interact with a receptor on the cell surface. And so as characteristic by protein hormones, they are made up of amino acids, which I'll be discussing the biosynthesis in just a short bit. And they're synthesized by beta cells. And first, they're synthesized initially as pre-insulin. And these molecules are made on the ribosomes of rough endoplasmic reticulum of the cells. Then what happens is proinsulin is then cleaved to proinsulin, which is then transported to the Golgi apparatus, which is then packaged into secretory granules, and then proinsulin cleaves to insulin and C-peptides in granules. So I'll show this in the next slide, what's going on. So as you could see, here's a picture of the structure of insulin on the top, indicated with A. And so the process I just described is in B. And so what happens is you have a proinsulin here with an alpha chain and a beta chain. So the alpha chain is blue and the beta chain is yellow. And you have a C peptide indicated in green. So it's what connects them both. And so what you could see is that eventually over time, the C peptide is cleaved and the two chains are bounded together by disulfide bridges. And so the C peptide is a fun name because C could be seen as it's a connecting peptide. And so some things to note about the C peptide, it just has a long half-life. And so it could be a good indicator of insulin production. So they can measure that in lab results. Right, next slide, please. So here's just a picture of what's going on cellular level. So next slide, please. All right, so I'm going to talk about how it's released from beta cells. So the beta cells are the pancreas. So as you see here in yellow, this is a beta cell, and this is they have a transporter for glucose called GLUT2. So top left. So GLUT2 transporters, very different from GLUT4. So there's different GLUT transporters. So here in beta cells, they have the GLUT4 transporters. This brings in glucose, and whenever it's available. And when it's inside the cell, it will go through the same processes of glycolysis, aerobic respiration, and it will produce ATP. So the ATP will then signal it will produce ATP, and then that ATP will then interact with potassium channels, which will then close them. And then what happens is that when you have the potassium trapped, this causes depolarization on the cell membrane, and it causes the voltage-gated channels of calcium to open up and take in calcium. And so then what happens is that the calcium then is a signal to release these vesicles of insulin out. So it will trigger exocytosis of the stored insulin. Next slide, please. So insulin release, as mentioned, there are several hormones that influence the interaction. So production of insulin is inhibited by epinephrine, and so these are done through interactions of the epinephrine to beta-2 receptors, which increase insulin, and there's also alpha-2 receptors, which decrease, which if epinephrine interact with, decrease insulin release. And so from what I've was reading, there's more alpha-2 receptors, so there's an overall effect of epinephrine is an overall decrease in insulin. And so, yes, so that's the next point. Alpha effect is dominant in the pancreas. And so this is just a response to the fight or flight response where through the sympathetic nervous system, specifically through epinephrine, the result is to raise our plasma glucose levels, which is good in times of stress because we want that regulation. Next. All right, so over here is just an overview of insulin's effects on different organs in the body. And so, so over here in the liver, it inhibits gluconeogenesis, inhibits breakdown of glycogen, promotes glycogen synthesis. In muscles, it promotes glycogen synthesis, increases glucose entries into the cells, mediated by GLUT4, as we mentioned before, and it stimulates the entry of amino acids. And finally, in adipose tissue, insulin increases glucose uptake in cells, again through GLUT4, increases triglycerol synthesis, as mentioned before, decreases triacylglycerol degradation, and it inhibits the activity of hormone-sensitive lipase and increases lipoprotein lipase activity. So a lot of these things I've already mentioned in the previous question already. Right, let's go to the next question. So again, just to remind you, just the overview again. So muscles for fat, they utilize GLUT4 to take in glucose, and their GLUT4 is dependent on insulin. And again, if there's no insulin, that means there's no GLUT4, therefore they're not taking in glucose. Next slide. All right, again, so there's insulin-independent organs, as I wanted to take note, and these are the brain and red blood cells. So the reason they call them that is because, so for one, these use the GLUT1 transporter for glucose uptake, and they're not dependent on insulin. So this transporter is not independent on insulin, and it will take up glucose when available in the plasma. So that's a good thing, right? Because we need red blood cells, they don't have mitochondria, and again, brain cells, there's no like fatty acid metabolism there, and so it has to utilize glucose or ketone bodies. And some other insulin-independent organs are liver, kidneys, and intestines. And going even further, even things such as nerves and lenses. Next slide, please. So here's just an overview of the different organs and what they utilize. All right, next slide, please. All right, so this is just an overview again, so I'm just going to go through it briefly. So insulin can promote glucose uptake, especially in skeletal muscles, and insulin also inhibits gluconeogenesis. And so the way it activates glycogen synthesis, I'll be mentioning that in the next slide. So, but for now, I want to take note of how it inhibits gluconeogenesis. So what it does is that insulin it has a positive effect on increasing levels of fructose 2,6 bisphosphate levels. So this stimulates, in the picture here, you might not be able to see it, but it stimulates PFK1. And so, and then what it does, it indirectly affects PFK2. So what it does is that the overall effect is that insulin activates PFK2. And so a glucagon, an opposing hormone to insulin, does the opposite. So what glucagon does is it inhibits PFK1, therefore by turn also inhibiting PFK2. So this is all in the sense of inhibiting insulin's effect on inhibiting gluconeogenesis and utilizing glucose for energy. Next slide, please. All right, so I've shown this picture again, but just show it again. So glycogen phosphorylase, the effects of insulin, if glucagon and epinephrine were to break down glycogen to glucose for utilization, insulin's effect would be the exact opposite, would be to activate glycogen synthase in order to produce more glycogen source. All right, next slide. And again, insulin's effects can be seen through fatty acid synthesis. So what it does is insulin activates the enzyme acetyl-CoA carboxylase, as shown on the bottom picture there. And so as you can see, insulin has a positive effect, and then glucagon and epinephrine have a negative effect on acetyl-CoA carboxylase. And so this is, from what we remember, this is a rate-limiting step, and this stimulates the production of fatty acid production, as seen on the top picture there, just a zoomed-in picture of what's going on from that bigger picture is that eventually that malonyl-CoA can be converted to fatty acids. And other points of note for insulin is it promotes protein synthesis, and it, as I was mentioning before, it stimulates the entry of amino acids into cells, therefore increasing protein synthesis. So insulin is very important when it comes to muscle growth. Okay, next slide. So again, just bringing up this slide again. So hormone-sensitive lipase just removes fatty acids from triglycerides, and this is an enzyme that is inhibited by insulin, and it's activated by glucagon and epinephrine. I just want to emphasize for this slide how it is activated by glucagon and epinephrine, and how to think about these different hormones is that, or think about glucagon and epinephrine is that they tend to oppose the effects of insulin. Right, next slide. And some other effects of insulin are it's for sodium retention, it increases sodium reabsorption in the nephron, and it lowers potassium. So this is a good point. So in patients with hypercalcemia, actually insulin is actually used as a form of treatment. They might pair it with glucose, as I read, to make sure that the patient has adequate amounts of glucose in their blood. And this is done through the enhanced activity of the sodium potassium ATPase pump in skeletal muscles. And finally, insulin inhibits glucagon release. Next slide. So just talking, I'll be talking about glucagon and cortisol to wrap up. So glucagon, as I mentioned many times already, it opposes the actions of insulin, and the response to this is low plasma glucose. And so if we know insulin to inhibit gluconeogenesis, and I showed you in the previous slide already, it in turn, glucagon increases gluconeogenesis. This also, again, increases amino acid uptake in the liver, so that's just a repeated point, and it activates lipolysis through hormone-sensitive lipase. So opposite, right, to insulin. And then finally, wrapping up with cortisol. So we know cortisol to be a stress hormone. So how this happens, or how it plays a role in in the effects opposing insulin, is that cortisol induces phosphoenolpyruvate carboxylase, or PEP, or PEPCK. And so we know that's a very crucial enzyme in gluconeogenesis. And so as cortisol induces the expression of this enzyme, it in turn creates more glucose, less glucose is taken up peripherally, and the net result of this is to increase the glucose in the blood. And this falls in line with cortisol's role, right? As we know it to be a stress hormone, right? And so if in times of stress, again, I want to stress that, or I wanted to say that it's good to have more energy storage, right, available to us in those times. And so that's the whole point of cortisol, and this is what it does. So next. And I just want to highlight here, this is where epinephrine also, this is where cortisol also shows up too, is that it enhances the effectiveness of hormones such as glucagon and epinephrine. So again, for glycogen synthesis or breakdown, in this case, cortisol would enhance the breakdown of glycogen. Okay, next slide, please. And then it activates lipolysis and adipocytes. So then this increases the amount of available free fatty acids, as well as increases total cholesterol and total triglycerides. And this stimulates adipocyte growth. And so, again, this is part of its whole role as a stress hormone. It increases the number of free fatty acids for energy utilization. However, and this also enhances the effects of glucagon and epinephrine. However, over time, high cortisol levels can develop patients gaining insulin resistance, which is it sounds like a good thing at first, but then it eventually over time, high cortisol levels can lead to that insulin resistance, and that could be a bad thing too. So, thank you. That's my last slide.
So for our next,
Okay, very good. I will try to summarize later on. I will just let you finish everything first, okay? Continue, doctor.
For the next discussion po, explain the occurrence of polyphagia, polyuria, and polydipsia. So first is the polydipsia. Polydipsia is a medical term used to describe extreme and excessive thirst. Often, polydipsia is linked to conditions that affect the renal system and can cause a person to urinate more often than they should. This increase in urination leads to the body to feel as though it needs to replace the liquid lost during urination. So since diabetes leads to an excessive amount of glucose in the blood, the body must do something to try to balance those levels. So the kidneys create more urine so that the glucose can be excreted quickly, thus restoring glucose levels to normal. This can lead to a rapid loss of fluid, and again, in turn, this will cause thirstiness. So for polyuria means urinating a lot, and it often goes hand in hand with polydipsia. Most people produce about 1 to 2 liters of urine per day, and people with polyuria produces more than 3 liters of urine in a day. Oliguria is 400 ml per day naman. So when glucose build up, it can enter tubules within the kidneys. If the glucose goes into the tubules but is unable to be reabsorbed back in the bloodstream, it leads to an increase in urination. While the kidneys attempt to filter out the glucose, they also filter out more water. This leads to overproduction of urine that they need to be secreted. So when one is extremely thirsty, they need to be urinated from drinking more liquids. So when one urinates more, they become more dehydrated and experience an increase in thirstiness. So with polyphagia naman, polyphagia is a medical term used to describe excessive hunger. There are times when an increase in appetite is expected, such as after an increase in physical activity or during hormonal changes, but eating will typically satisfy the hunger and appetite levels will normalize following food consumption. In the case of polyphagia, eating will not stop the hunger. So in those with diabetes, since glucose is not easily transferred into the cells to be used for energy, this can be due to either low insulin levels or insulin resistance. The body will continue to send signals to the brain that it is hungry because it isn't getting any energy from the glucose itself. So again, with polyphagia po, since hindi nag-enter yung glucose that is sa cell, sasabi niya sa brain na kulang pa ako ng energy. So, kakain pa rin ng kakain yung tao kahit madami na tayong glucose sa katawan. So, next discussion is explain the molecular basis of clinical manifestations of diabetes mellitus. So, for HbA1c. So, HbA1c is a minor fraction of adult hemoglobin which is formed slowly and non-enzymatically from hemoglobin and glucose. Because of erythrocytes are freely permeable to glucose, HbA1c is formed throughout the lifespan of erythrocyte, which is 120 days. Its rate of formation is directly proportional to the ambient glucose concentration. The concentration of HbA1c therefore provides a glycemic history of the previous 120 days, which is the average lifespan of erythrocyte. HbA1c provides important information about recent average glycemic control. It is an integral part of management of patients with diabetes and is used to monitor long-term glycemic control and as a measure of the risk for the development of diabetes complications. So So HbA1c should be measured approximately every 3 months to determine whether a patient's metabolic control has been reached or has been maintained within the target range. So the HbA1c is primarily used to monitor the effectiveness of glycemic therapy and as indicator for therapy to be modified. HbA1c underestimates average glucose levels in conditions that shortens the average circulating red blood cells lifespan, such as hemolysis, sickle cell anemia, transfusion, cystic fibrosis, and iron deficiency anemia. So HbA1c will be further discussed later on for the diagnosis. So atherosclerosis, this causes lipolysis of storage of fat and release of free fatty acids, activation of hormone-sensitive lipase, hydrolysis of stored triglycerides, releasing large quantities of fatty acids and glycerols to the circulating blood. In turn, this increases the concentration of free fatty acids in the plasma, and free fatty acids are used by the cells as main energy substrate except for the brain. Increased plasma cholesterol and phospholipid concentration. So excess free fatty acids again will cause conversion by the liver, phospholipids to cholesterol. So phospholipid, cholesterol, and triglyceride formation in the liver released by lipoproteins. So increased plasma lipoproteins as much as 3-folds will now cause the atherosclerosis. So with hyperglycemia naman, during digestion, your body breaks down carbohydrates for foods such as bread, rice, and pasta into various sugar molecules. One of these sugar molecules is glucose as a main energy source of the body. Glucose is absorbed directly into the bloodstream after you eat, but it can't enter the tissues since there is insensitivity to insulin. So when the glucose level in the blood rises, it signals your pancreas to release insulin. The insulin unlocks your cells so that glucose can enter and provide the fuel your cells needs to function properly. So again, this mechanism is discussed by Dr. Adrian earlier. So any extra glucose is stored in your liver and muscles in the form of glycogen. So this process lowers the amount of glucose in the bloodstream and prevents it from reaching the dangerous levels of glucose. So diabetes drastically lowers insulin effects on your body. This may be because your pancreas is unable to produce insulin, which is the type 1 diabetes, and maybe because your body is resistant to the effects of insulin, which is type 2 diabetes. As a result, glucose tends to build up in your bloodstream and may reach dangerous high levels if not treated properly. So insulin or other drugs are used to lower blood sugar levels. So for our next discussion, differentiate the procedures for diagnosis of diabetes mellitus. So all three P's are found in most diabetics, but for those with type 2 diabetes, they may be less noticeable than in those with type 1 diabetes. In some cases, those with diabetes may not experience these symptoms at all and could still have the condition. So for a healthcare provider to diagnose diabetes, they will take note of these symptoms and perform some tests. So some tests for diabetes mellitus, random blood sugar. So with random blood sugar, this measures your blood sugar at the time you're tested. You can take this test at any time and it does not require fasting. So this is usually requested during insulin shock and hyperglycemic ketotic coma. So if blood sugar levels are shown to be 200 milligrams per deciliter or higher, it indicates that someone has diabetes. So with fasting blood sugar, it measures overall glucose homeostasis. This requires person to avoid all food consumption for 8 hours. So typically this is done overnight. If a person has a level of 126 milligrams per deciliter or higher after a fasting test, they have diabetes. So non-diabetic should show less than 100 milligrams per deciliter. Impaired plasma glucose or pre-diabetic should be around 100 to 125 milligrams per deciliter. And with diabetic patient, more than 126 milligrams per deciliter. So with glucose tolerance test, this test also requires an overnight fasting Healthcare providers will measure your blood sugar levels before you drink a liquid that has glucose. And then again, after you do, the blood sugar levels would be checked anywhere for 1 to 3 hours after drinking this liquid. So usually this OGTT test is done with pregnant women to detect gestational diabetes. So for non-diabetic, this is less than 140 milligrams per deciliter. Impaired plasma glucose or pre-diabetics, 140 to 199 milligrams per deciliter. With diabetics, more than 200 milligrams per deciliter. So again, ang ginagawa dito, may muna, fasting yung patient, tapos kukuhaan ng dugo for FPS, tapos take ng liquid with glucose load. Then after 1 hour, kukuhaan ulit. After 2 hours, kukuhaan ulit. And hindi usually hanggang 2 hours lang. Bihira na after 3 hours, iti-take ulit yung blood ng patient. So with glycosylated hemoglobin or HbA1c test, this test looks at a blood marker that gives an estimate of the average blood glucose over the past 2 to 3 months. It is the largest subfraction of a normal hemoglobin A in both diabetic and non-diabetic patients. It is hemoglobin A that is irreversibly glycosylated. Including hemoglobin that may also be glycosylated or lysine residues, it represents the weighted average of glucose levels, with youngest erythrocyte contributing to a greater extent to older ones. So dietary status on the day of the test has no effect of HbA1c. So again, this is the average glucose of the patient for 3 months. So hindi natin kailangan ng fasting dito. Hindi siya kailangan ng overnight fasting. So for pre-diabetic, this should be 5.7 to 6.4%. And for diabetes mellitus, this is more than 6.5%. So usually, this is done with patients na may normal types ng blood. Because pag shorter ang lifespan ng blood natin, red blood cells natin, affected yung result ng glycosylated hemoglobin. That's why, kapag may problema like hemolytic anemias or sickle cell anemias, gumagawa din tayo ng result such as fructosamine. So the fructosamine test for diabetes is a blood test that measures average blood glucose over the 2 to 3 weeks prior to when the test is performed. So the fructosamine test measures glycated protein in the blood instead of glycated hemoglobin. So again, yung HbA1c is a glycated hemoglobin while fructosamine is glycated albumin. So sugar molecules present in blood adhere to proteins. So these proteins circulate in the bloodstream for 14 to 21 days. So measuring them provides a picture of amount of sugar in your blood for the time period. This is also known glycosylated or glycated albumin, plasma protein ketoamide. So it is a reflection of short-term glucose control, such as for 3 to 6 weeks. May be useful for monitoring diabetic individuals with chronic hemolytic anemias and hemoglobin variants, which has decreased RBC lifespan. So for non-diabetics, this should be 175 to 280 millimoles per liter. Controlled diabetic, 210 to 421 millimoles per liter. Uncontrolled diabetes, 268 to 870 millimoles per liter. So for glycosuria, glycosuria occurs when plasma glucose levels exceeds 180 milligrams per deciliter with normal renal function. If glucose is detected in urine at any point, evidence for this condition is also obtained. Although absence of urinary glucose does not in any way rule out diabetes. So for diagnostic criteria for diabetes, FBS or fasting blood sugar should be more than 126 milligrams per deciliter. Random blood sugar should be more than 200 milligrams per deciliter, and also do our OGTT test. HbA1c should be more than 6.5%.
Okay, so now let's go to the prevention and treatment of diabetes mellitus. So under the treatment, we have dietary management and physical activity, insulin therapy, as well as oral medications. But before we discuss those, I just wanna show this to you, the ominous octet. So, ano nga ba itong ominous octet? So, the ominous octet is a phrase referring to the core defects implicated in type 2 diabetes as well as its pathogenesis. So, this is, by the way, made by Dr. Ralph DeFronzo, a professor at the University of Texas. So, according to him, patients who are destined to develop type 2 diabetes mellitus inherit a set of genes that makes their tissues, particularly the liver and the muscle, very resistant to insulin. So he called this the triumvirate, wherein it manifests as decreased insulin secretion, as you can see dun sa upper left, increased hepatic glucose production sa lower left, and decreased glucose uptake by the muscles. So ang nangyayari dito is, early in the natural history of the disease, the beta cells of the pancreas secrete sufficient amounts of insulin to offset the insulin resistance in the liver as well as in the muscle. So healthy pa siya. However, habang tumatagal, the ability of the beta cells to secrete the insulin declines. So habang nagdi-decrease si insulin, unti-unti nang nagmamanifest yung insulin resistance sa liver, leading to an increased hepatic glucose production throughout the sleeping hours. So other problems that needs to be addressed in this octet includes increased lipolysis, since decrease nga yung insulin, which is a fat sparer or anti-lipolytic hormone. So this exacerbates the three core defects of type 2 diabetes. As for the gut, makikita natin dito sa upper side, as for the gut, which is still part of the endocrine system, it releases two important incretin hormones. So one is your glucagon-like peptide 1, or your GLP-1, and the other one is your glucose-dependent insulin atrophic polypeptide, or referred to as GIP. So these incretin hormones are responsible for 70% of the insulin secreted in normal people without diabetes, typically after meal. So in patients with type 2 diabetes, since decrease yung incretin hormones natin, especially the GLP-1. So since decrease nga siya, decrease din yung insulin production every after meal, leading now to postprandial hyperglycemia. So on the left naman, we can see increase yung glucagon secretion. So patients with type 2 diabetes also have increased glucagon secretion of the alpha cells. And we know that the liver is very sensitive to glucagon. So kapag nadedetect siya na increase si glucagon, mag-increase din yung production niya ng glucose. Sa kidney naman, in here, increase glucose reabsorption. So normally without diabetes, nagkakaroon tayo ng glycosuria, which was discussed earlier, kapag na-reach na yung renal threshold na 180 milligrams per deciliter. So that is to maintain the normal plasma glucose level sa atin. However, in patients with type 2 diabetes mellitus, impaired yun. Ang nangyayari, nag-i-increase yung renal threshold more than 180 milligrams per deciliter. So, ibig sabihin, kapag nag-reach sila ng 180, hindi sila agad nagkaka-glycosuria. So, nag-retain lang sa body yung plasma glucose, leading now sa hyperglycemia. So, lastly, neurotransmitter dysfunction. Nadi-disrupt din yung normal functioning ng neurotransmitters na nagre-regulate ng appetite natin, like your serotonin, catecholamines, and dopamine, na nagko-contribute sa dysregulation of appetite and excess caloric intake. And this now results in weight gain. So yun, nagkakaroon tayo ng polyphagia. So for the dietary management and physical activity, diet and exercise are fundamental in the treatment of diabetes. So the caloric content of the diet should be adjusted in each individual in accordance with the body mass index and regular physical activity. It is recommended that protein should constitute 10 to 20% of caloric intake and fats less than 30% with less than 10% saturated fats. And moderate regular exercise, recommended is 30 minutes per day, is very beneficial since it reduces glycemia by increasing sensitivities to insulin and improves lipid profile as well as lowering blood pressure. So itong moderate regular exercise, nakadepende din to minsan sa age natin. So for insulin therapy, there are different types of insulin. For the first one, we have rapid-acting insulin, which starts working somewhere between 2.5 to 20 minutes after injection. And it acts more quickly after a meal and is similar to the body's natural insulin. So the brand names under this is your Humalog or Lispro. For the short-acting insulin naman, it begins to lower blood glucose levels within 30 minutes and has its maximum effect 2 to 5 hours after injection and lasts for 6 to 8 hours. So the brand names po under this are your Humulin or Novelin and your Velosulin, which is injected via insulin pump. For the intermediate acting insulin naman, it is usually used before diabetics go to sleep. And it is cloudy in nature and need to be mixed well. So NPH po is under this. And lastly, the long-acting insulin, which is if insulin is needed for an entire day, this one is usually the choice of doctors. So ito yung usually nilang piniprescribe. And the brand names under this is the Lantus, which does not peak and the duration is 20 to 24 hours. And your Levemir, which also has a duration of 24 hours. And for the oral medications, of course, we have your metformin, which is one of the most commonly prescribed drugs for those with type 2 diabetes. It works by reducing the amount of sugar that the liver releases into the blood. It also makes the body respond better to insulin. Second one is your glibenclamide, which works by increasing the amount of insulin that the pancreas produces and is best paired with a proper diet and exercise. We also have pioglitazone, which helps improve glycemic index control in patients with type 2 diabetes, glyclazide, which is often prescribed to obese diabetics, glimepiride, and green stevia, which is not a medicine. However, it could effectively help those trying to control their blood sugar level. It is a great sugar alternative that is plant-based and contains no calories. And lastly, to avoid the complications of atherosclerosis, lipid-lowering drugs are also given to diabetics patients, such as your atorvastatin and fluvastatin. So that's all po for our report today. Thank you po.
Okay. So the only thing that I want you to remember in here is more of the part of the second reporter. Okay? So answer me as we summarize the effect of diabetes mellitus on the metabolic pathways for biochemistry. Okay? This will be the concentration of the exam that I'll be giving you. Ako ang gagawa, I don't know if it's 5 items, okay? Or a 10-item exam for diabetes mellitus. Ito ang pinaka-importante pagdating sa biochemistry for you to integrate the different metabolic pathways. And I appreciate, okay, the group for giving me a very concise discussion of the metabolic pathway effects in diabetes mellitus. The clue in here is, as long as you know the effect of insulin in every pathway, you know already what will happen in diabetes mellitus, because that's just the opposite. For example, okay, just an example, insulin is an anabolic hormone, meaning to say, or all anabolic pathways will then be increased by insulin. Mga genesis, obviously, aside from gluconeogenesis. Get it? So, if that is the case, then just make it opposite in effect if there is diabetes mellitus. Example, insulin promotes glycolysis. In diabetes mellitus, what will happen in glycolysis? Obviously, it will bring it down. It's just an opposite. Okay? During the fed state, what happens to what is high during the fed state? It's insulin. Thereby, during fed state, glycolysis is high, Krebs cycle is high. Get the point? Lipogenesis is high. Okay. Cholesterol synthesis is high. Get the point? Protein synthesis high. Just imagine it. Imagine. In, okay, the fed state, what is high? Glucose. Thereby, anything that produces glucose will be low. Gluconeogenesis low. Glycogenolysis low. But glycogenesis is high. Lipolysis is low. Ketogenesis is low. Can you get my point? So let's summarize it. Okay? So help us, reporter number 2, because this is your part, right? Okay. I will mention, okay, I will help you, don't worry. I will help you if you are confused with it, okay? In my exam, I will just mention it could be the effect of insulin or it could be the effect of diabetes mellitus in the different pathways. That's the way we are going to do the examination. Okay. For example, my question is diabetes mellitus effect in the different pathway. You will just answer me high or low. Get it? Okay, all of you. When I say then, carbohydrate metabolism first. In diabetes mellitus, glycogenolysis is
High.
in diabetes mellitus, glycogenolysis is the second reporter told me it's
High.
high, obviously. Gluconeogenesis is
High.
high as well. Okay? Glycogenesis is, yes, answer it. Sinasabi na ni Dr. Todio.
Low po.
Glycogenesis is
Low po.
low. Okay? Glycolysis is
Increase.
glycolysis is there's nothing, okay? Nothing is being no glucose is entering or used by the cells in diabetes mellitus. There's a problem, thereby your glucose cannot be used. Thereby glycolysis is
Low po.
low. That's the very reason why we will stick with the other source of ATP. Because glycolysis cannot happen. We will then proceed or shift into another form of ATP formation. Thereby, in diabetes mellitus, beta oxidation is
High.
high. Lipolysis is
High.
high. Okay? If you can analyze this class, you're good. Okay? Lipogenesis is come on.
Low.
Low po.
Low. Ketogenesis is
High po.
High.
high. Okay? Cholesterol metabolism is
High.
High.
during diabetes mellitus already. Just remember, cholesterol metabolism is high during the fed state. During the fed state, insulin is high. Thereby, your body will give way to cholesterol metabolism. Because in cholesterol metabolism, what do I need? Acetyl-CoA. Get it? I will then give way to your cholesterol metabolism because your acetyl-CoA in diabetes mellitus will be shifted to ketogenesis. Get the point? So cholesterol metabolism is low. Protein synthesis is
So,
obviously low because insulin increases protein synthesis. Can you get the point? From that summary alone, we can make 10 questions already. Okay? Master that. That's the very essence of biochemistry when it comes to diabetes mellitus because that's analysis. If you've noticed, I have not mentioned anymore what's the normal blood sugar level. That can be memorized. Even without a proctor, even without an educator, you will know that. Okay? Kahit wala pong magdidictate sa inyo kung ano ang normal, just read it, you will know that. But for the metabolic pathways, without somebody explaining it, that would be hard. That's the very reason why diabetes mellitus is the finale CBL, finale case. For the reason that your proteins are affected, fats are affected, carbohydrates are affected. You are expected to know already the different pathways, right? Okay? So concentrate on the summary that I have given. Sure enough, you will have a perfect score in your CBL for diabetes mellitus. Okay, questions? Questions? Concentrate on the discussion of reporter number 2. I appreciate all the figures being made by the group maybe or by just reporter number 2. It's complete, it's comprehensive. Concentrate on that. You will learn a lot from those figures even until the board exam. Okay? So questions? Questions? Biochemical lang po yung kinoncentrate ko. Kasi yung mga gamot naman, you will learn that in your pharmacology. Yung mga normal values, you will learn that in your internal medicine.